start off a new topic, which is orthopedic radiology, which is kind of a fun topic to do. So I hope you enjoy these lectures as much as anyone possibly can. So let's go ahead and I think I sent out the link for this about an hour ago to your class rep. So hopefully you got that and you've had time to distribute the lecture around. So let's go ahead and get started. Orthopedic radiology, what does that entail? Well, it's just what you would think. It has to do with the skeleton. So before we get started, I'm going to get off on a little bit of a path, and I want to encourage you guys, even though you still have a year and a half or so left in your schooling, to start thinking about possibility going forward of doing specialization in veterinary medicine, doing something other than a general practitioner. Not that there's anything wrong with that at all. That's a very challenging, difficult, fulfilling job. But there are other avenues in veterinary medicine, as you're aware of, and one of which is to specialize and do the internship residency route after veterinary school. And so if you start thinking about that now, that's the time to think about it. You will also be exposed to different specialties when you get out, especially to the teaching hospitals and spend your last year in a clinical setting where you'll be exposed to working with board certified surgeons and neurologists and radiologists and pathologists and ophthalmologists and dermatologists and you name it. So now's the time to start thinking about it. I think in your stage, everybody thinks, oh my God, I just want to get out of school. I need to start making some money. I got to pay off some of this debt, all that kind of stuff, and that's all well and good. But I think you should at least consider it going forward because there's some advantages. There's also some disadvantages to it, but there's a lot of advantages to it going forward. So when you do start thinking about it, one of them that you could specialize in or consider is radiology. And that's obviously what I did. I'm a little bit biased in that respect as far as my options and what I would advise you. But I do think, just like this slide, radiology is the best. And it's kind of fun for me if I talk to people going forward, students and stuff like that. And if I talk to a bunch of old practitioners, it's surprising the number of practitioners that you talk to and they say, hang on just a second. They say that, would you be a veterinarian again? And a lot of the practitioners, unfortunately, seem to say, no, I wouldn't. It was a lot of school, I'm not sure I would do it again. Maybe I'd go into human medicine, maybe I'd go into computers or law or whatever. But I'm one of the people that I still think, number one, veterinary medicine is the best career out there. If I had to do it all again, I would definitely do it all again. I'd be a veterinarian again. I would highly encourage anybody out there also to be a veterinarian. It's a great profession. It's a very well-respected profession. You get to work with fantastic people and fantastic colleagues. The trade shows are fun. Everything about it, in my mind, is awesome, and it's better than I thought it would be when I was in your stage. As far as radiology, I'm also biased for that, obviously. I think it's the best of the specialties for lots of reasons. Number one, there's a lot of jobs. There's a lot of opportunity. You can make decent money being a radiologist. And you get to work with some really cool tools and toys and things like that. Nothing beats an MRI machine and an ultrasound machine and a CT or radiographs even. So I think it's the best. I don't really get burned out. A job's a job, but I've been doing this for over 30 years now, and I don't get that burned out. I still kind of want to go to work every day, which is unusual for anybody doing anything after 30 years. But the radiology part of it still is fun. I don't get to touch animals except for my own, except when I do ultrasounds and then I touch animals. But that's okay. I don't have to deal with the general public and owners, which overall, that is probably a really good thing. But I do have clients, but my clients are the referring veterinarians for the most part and not the owners. So, the other reason I don't get burnout is there's different modalities. Every day I come in, I know I'm going to be reading some kind of images and doing ultrasounds and things like that. But on the other hand, there's MRI, which is totally different than reading an X-ray, and an ultrasound, which is totally different than MRI and X-rays. And so the different modalities in radiology, I think, also help you from feel like you're stuck in Groundhog Day and doing the same damn thing every day. Um, Again, I mentioned that we have cool, expensive toys with lots of buttons and lots of lights. If you just sit in front of it, you can be the dumbest person on earth, but you sit in front of that and you have a little bit of a grin on your face and you just look smart because you're in front of this fancy looking machine. And I, believe me, I need all the help I can get. So in a clinical setting, you also get to, it's kind of fun because radiology is the hub of any hospital. Everything seems to need imaging. And so everything, whether it comes in through internal medicine or critical care or neurology or surgery, for the most part, everything ends up coming through radiology. And so you have a lot of interaction with all of the other services and specialists in the hospital. And everybody likes to come down and get your opinion on things. So that's kind of fun. Again, the future looks really bright for radiology. There's lots of jobs. We can't train enough radiologists to fulfill the jobs. If teleradiology is a huge thing right now. That's what my company does. The nice thing about that is you can do it from anywhere in the world. All you need is a computer and a good fast internet connection and a little bit of equipment, and you're ready to go. And so it doesn't restrict you from living in a little town, a big town, or even in any specific country. You can do it anywhere you want. And for people that want to have families and things like that, it's really nice because you could also do it pretty much any time of the day that you would want to do it. So there's lots of advantages to that. So here's just a couple of examples that will kind of get you excited as we start progressing into the orthopedic stuff and radiology in general. So this is a nuclear medicine bone scan of a human patient. This is a 37-year-old female. She presented to her physician with mammary carcinoma, so breast cancer. And we know that breast cancer in humans can be aggressive and it can readily metastasize to lungs and to bone, which obviously is not a good thing. And so one of the ways in human medicine, and we also do this in veterinary medicine in a few select areas, is nuclear medicine procedures. And this is a bone scan of this patient. And what we're doing with the bone scan is we inject a little bit of a liquid radioactive radionuclide called technetium, which is, I don't want to get too complicated, but it's attached to a phosphorus molecule. When you inject it, it localizes in the skeletal system in patients and causes it to become kind of black like this. So we're actually looking at radioactivity coming from the skeletal system, and we're looking for hotspots. We're looking for focal black areas that may represent tumors in this patient. But you have to keep in mind that in animals and in people, there are normal areas in the body that normally have hotspots. They're normally black, and you have to keep some common sense in mind. So here, this is a dorsal view. This is a ventral view, or posterior and anterior in a patient, in a human, a guy it would be called. And we know that this pharmaceutical is excreted in the kidneys and through the urinary system. And so these two little blobs right here, these hot spots, those black areas, are kidneys. So that's just the pharmaceutical that we gave being excreted into the urinary tract. And this is her urinary bladder, and it's got a little bit of fluid in it. And so those hot spots are considered normal. That's not a big deal. Okay. And then also this stuff is a lot of times accumulated a little bit in the nasal passages, in the glands in your nose. And so that would explain that hot spot right there in the middle of her nose. And those we don't worry about, those are normal. Okay. And then we have to look for common sense things. So we would look for other focal hotspots. Well, we got a little hotspot here, but there's also one over here that pretty much is the exact same thing. And anytime it's symmetrical like that, it's probably normal and just a normal variant for this person. Okay, there's another little hotspot here. Well, there's also maybe one here. So maybe that's also kind of normal because it's symmetrical. On the other hand, I got three little hotspots right here on ribs. So 1, 2, 3. Okay, so those are a little worrisome. And that's what we would look for metastatic disease in this female patient. And, that would worry us a little bit. So those kind of raise a red flag. On the other hand, using your brain, using common sense, if this patient with a mammary carcinoma decided that it was going to metastasize to the skeletal system, what do you think the odds are in betting that the lesion would metastasize to 3 consecutive ribs all in a row at the same location? Or do you think it would be more likely if it was metastasizing, it would go to one rib here, maybe one down here, maybe one over here, one way over here, kind of random? What would you think would be more likely with true metastasis? Random, yeah. It would be really unusual for a tumor to go to 3 consecutive ribs, all on the right side, all at the same level of the ribs. And so for the most part, that's what the radiologist would do. That's called the synthesis part of thinking about, the images. Chances are that's due to previous trauma. Maybe the lady was in a car wreck in the past, and those are old healed chronic rib fractures. That would be more likely. I couldn't completely rule out some kind of weird atypical metastatic lung disease, but it's probably not very likely. Just the fact that it's positioned, all 3 of them are right in a row on the same, region of the ribs. Okay. So this was read out basically as a negative bone scan with no definitive evidence of metastatic disease. So here we go into another modality in animals and mostly in people. Now we do another imaging modality called PET scanning. Probably most of you have heard of PET scanning, and PET scanning has nothing to do with PETs as we would think about it. But PET is an acronym that stands for positron emission tomography. It is another nuclear medicine procedure that is done in people all the time, all over the world, and is starting to venture off also into veterinary hospitals. Well, PET scanning is, like I said, another nuclear medicine procedure, but now we're imaging actually a radiopharmaceutical that images where glucose is uptake in the body. And so any place that has high metabolic activity and is utilizing a lot of glucose will now produce a hot spot. Okay. And then we have to, same thing as the last one, we have to consider, well, where normally would we have glucose utilization? Well, in a normal patient, the heart muscle has a lot of glucose. It's always beating, it's always working, so it needs to be fed a lot of glucose and nutrients. And so this area right in here spinning around is this lady's heart. So that doesn't bother me because we know the heart has a lot of metabolic activity. This pharmaceutical is also excreted in the kidneys and urinary bladder. So these 2 big hot spots here spinning around, and that one there is the urinary bladder and the kidneys. Those don't worry me. Okay. Another one, we can't see it, would be the brain. Most of us have high utilization of our brain throughout the day. And so the brain typically has increased uptake of this radiopharmaceutical we use for PET imaging. Okay. This is the same lady that we did the bone scan on that was read out as negative for metastasis. On the other hand, PET imaging images not bony stuff, but it images glucose metabolism. And so all of these other hotspots in the soft tissues all over this lady, up in here in her chest and the craniomediastinal region, some in the bone, all of these down in here, some in the, the pelvis, even the soft tissues of the rear limbs, all of those are metastasis. Okay. So even though the bone scan was normal, except for probably chronic fractured ribs, we do PET scan, which images in a different way in a different modality. And now we know that this lady, unfortunately, has metastasis all over her body. It's just not showing up on a bone scan. So this tells us a couple of things. One, radiology is cool. It's cool to have spinning images of a dog or a person in front of you like that. And number 2 is no modality is perfect. So radiographs don't show everything all the time. Ultrasound doesn't show everything all the time. MRI doesn't show everything all the time. Neither does PET imaging. Sometimes one modality is better to look for a specific thing and more sensitive than other modalities. And so that's part of the charge of being a radiologist, is to know that kind of stuff and which modality is going to be the most likely to give you the biggest bang for the buck. Okay. So here's another patient. This is another patient with a PET scan. So again, there's the heart, there's the kidneys. That doesn't bother me. This is a little uptake in the stomach. That doesn't bother me. But what does bother me in this person that had lymphoma is these couple of little hot spots right in the axillary or underarm region right there, and all of these chaining down into the craniomediastinal space. Those hot spots represent enlarged lymph nodes, and that's metastasis from lymphosarcoma. And again, if you don't think that's cool by looking at that, then you got something wrong. That's cool. That's something that internists don't get, that surgeons don't get, that neurologists don't get. We get to play with this cool stuff. Okay. And so that should get you excited. Here's a blue man. Same thing, it's a different color palette, but this person had melanoma. So now we look at where's our normal hotspots? Brain. Okay. So this guy's got an active brain. It's using glucose. These are the thyroid glands. That doesn't bother me too much because, again, they're pretty active. There's the heart. That's okay. There's some little hot spots in his kidneys. There's his bladder. But all of this down one leg is all diffuse metastatic melanoma, a skin cancer. And so again, that's not going to show up on an X-ray. It's not going to show up in an ultrasound. It probably won't show up on an MRI or a CT, but PET scanning will show it up. And so that in human medicine, that tells us, number one, what's the long-term prognosis? What's the best way, that's going to influence how the best way we're going to treat this patient going forward. In veterinary medicine, it does the same things, but also in veterinary medicine, because money is typically an object and something to consider in veterinary medicine, it also helps guide the owners of how much do they really want to spend. Okay, getting going on the animals in orthopedic radiology. Number one, and I'm sure Dr. Warner told you this, number one rule with radiology always is to do what? Let's see if he told you this or not. I'm sure he did. So what's number one rule with radiology is always do what? Yeah, always take at least two views. You have to take what's called orthogonal views at 90 degrees to each other. If you take just one lateral view of the thorax or the elbow in this case, you're going to miss a lot of stuff, and you're going to not be a good radiologist and a good veterinarian. Okay, so here is a dog's elbow, and I know you're not experts on elbow radiographs yet, but here's a dog's elbow. To me, it looks relatively normal. That's the humerus. Here's the ulna. There's the radius. The elbow joint looks like it's intact. Everything looks good. There's some soft tissue swelling, and these little opacities here probably represent some edema or gas in the soft tissues. So I would say the bones look pretty good in this one, but the soft tissue is questionable for evidence of recent trauma. Okay, but again, rule number one is you always have to get two views. So let's get the other orthogonal view at 90 degrees. Okay, now does it look so normal? No, the whole elbow is out of place. It's out of joint, and the doctor word for that is luxated. So this elbow is luxated. We can still see this soft tissue swelling and these gas opacities. So based on this view, I'm not sure I would know to call that. And so if you just shot a lateral view of that, you're going to think, well, I think he's just got soft tissue swelling and we'll just treat him for that. And this view here, no, there's a lot more involved. Okay, so you always have to get two views. Okay, so the last time when we started talking about neurologic radiology, we said it was confined, our discussion was confined to anything in the skull, as well as the axial skeleton. Now we're talking about all the bones outside of the skull and axial skeleton. So everything else, so the ribs and the appendages in the pelvis is going to be included in this discussion going forward. Okay, we have to start off with basic stuff to make sure everybody's on the same page and we're all thinking alike. The first thing we have to think about is, even though cortical bone, the hard bone that makes up your femur and your pelvis and your humerus and all that kind of stuff, it's really hard. And sometimes you think of it, it doesn't change. Well, it does change, but it takes a long time to change. And just because that bone is solid and rock hard and things like that, it's still alive. It's a living thing. Okay, so the normal living bone in all of our skeletons is in constant homeostasis. It has a desire and in normalcy to always stay the same. Okay. And there is a constant exchange of bony lysis going on, which the doctor word for that is osteoclastic activity. And there is a constant bony production going on, and the doctor word for that is osteoblastic activity. But the key is as we age and all of that, they have to balance. You have to have enough osteoblastic activity to exactly balance the osteoclastic activity, where the bone over time stays the same. But it's a good thing that we get that, because we get tired old bone cells, and basically the osteoclastic activity gets rid of them, and we make new pretty bone cells. But overall, over time, everything stays in homeostasis or stays the same. Any way that you can alter that balance can lead to orthopedic abnormalities. So if osteoclastic activity starts to win and there's more osteoclastic going on, then you will have over time an overall decrease in bone quality and the amount of bone, because more of it's being destroyed than being produced. On the other hand, if the blastic activity is more prevalent, then that's not good either. Now you're going to have bones that have too much bone. You're laying down too much bone. And that's not a good thing either. That can lead to abnormalities and sclerosis of the bone and abnormal blood flow in the bone and blood supply to the bone and oxygen supply to the bone, things like that. So that's not good either. It has to stay in balance. Okay. The other thing to keep in mind is on radiographs, when you're looking at the radiographs of a skeletal part, it's very insensitive for osteoclastic activity. And by that, you usually typically have to have a loss of 30 to 50% of the bone before you're ever going to see anything on radiographs. So if you have something that's causing osteoclastic activity, an infection of the bone, or a tumor that's very early on, if 5% of the bone is being destroyed, you're probably never going to see it on radiographs. Okay. If 20% is gone, you're probably also never going to see it. Once you get into 30 to 50% of the bone that is already lytic and gone, that's when you're going to start to see it on radiographs. So it's pretty insensitive. Now, if you were doing MRI or CT or PET scanning, you might see it earlier on, but radiographs, it's pretty insensitive. A lot of the bone has to be gone before you're ever going to pick it up. Okay. The other thing to keep in mind is, again, bone is unlike soft tissue. Changes happen, but they take time. And so if you have an infection of the bone or a tumor and it's starting to cause bony lysis or destruction of the bone, you're not going to see it overnight. It may take 7 to 10 days or up to a couple, 3 weeks sometimes, depending on how aggressive it is, before you're going to see it. So not only do you have to have a lot of bone loss before you see it, it doesn't happen quickly, and it takes time for that to happen and to be recognized. Okay. Also, because bone, even though it's living and always undergoing this constant homeostasis of osteoclastic and osteoblastic balanced activity, bone has very limited response to injury. Okay. So whether it's a fracture or trauma, or you bump the bone and you get a periosteal reaction that starts to happen to the bone, or it's a tumor or an infection, bone has very limited ability to heal itself, and those limited abilities take time. Okay, so it's not going to heal itself in a week. It typically takes a lot more time for bone to heal itself. And there's different things that we're going to talk about coming up that will influence how quickly or how long it takes for bone to heal itself. Okay. Okay, some bony changes that you're going to see on radiographs are very subtle, and other ones cause significant change. So it depends on what the process is that's causing the bone to heal or to be destroyed, where it's going to take time to see that. So very commonly, it's really one of the best things that you can do is take serial radiographs. You take different films over the same time, over different times. So you may get a dog that comes in, he's limping on the right rear leg, and you take radiographs and you see something in the femur of the bone, and you think, I don't know, it looks worrisome to me, but I'm not sure. It's very subtle. It's kind of iffy. It's equivocal, so what should you do? Well, one of the best things you can do is probably wait, take advantage of the fact that we said sometimes these lesions can take 10 to 14 days to actually manifest themselves and where you can see them. And so one of the best things you can do is you say, I don't know, Miss Jones, this place here, it kind of worries me a little bit. We really need to get your dog back in. And guess what? 10 to 14 days. And let's just repeat the films. Let's see if it's still there, if it's gone away, or now it's more obvious to me. Okay. So a lot of times you want to repeat films over 10 to 14 day periods to see how that equivocal possible lesion may change. Now that we're talking about orthopedics, you have to remember that we're not just talking about, when we do our radiographic evaluation, not just of the bones. We also have to evaluate the soft tissues around the joints and around the bones, and that's part of our complete radiographic evaluation. So one of the first things that we have to keep in mind, and I don't know why, but this confused me this concept here confused me when I was in vet school, when I was sitting in your stages, probably because I slept through a lot of it and I was hungover through a lot of it. But anyway, that's beside the point. As we talk about this, now I got the concept, but I think, if I explain it to you, it's easy to think about now. So there's 2 types of soft tissue swelling, okay, in around bone and joints. Okay. And we want to classify those. Anytime you're looking at an x-ray, you always want to think about this, and you want to classify them as to what type it is. So there is extracapsular swelling and there's intracapsular swelling. And I don't know why I didn't understand it at the time, but it was a hard concept for me. So extracapsular swelling is swelling of the limb, the soft tissues around a limb, that is not centered around a joint. The swelling is not arising from the joint itself. It's not coming from the joint space, the synovial fluid, the synovial membrane. It's not coming from the joint, and therefore it's not centered around the joint. This may be stuff like cellulitis, a penetrating wound in the mid-thigh region, in the mid, portion of the humerus in that area, around that area. So it's not around a joint, and it can be due to blood, pus, edema outside of a joint. The key is it's not centered around a joint. That is opposed to intracapsular effusion. Intracapsular effusion, there's something wrong actively inside the joint, and therefore the swelling is coming from and centered around a joint space. It can still be due to blood, pus, edema, but it is centered around the joint space because it is actually starting and arising from that joint space. Okay, so having known that, we can see here's the distal tibia of a dog, here's the tarsal bones, and he's got this obvious messed up bony lesion right in here. Okay, so I see all of this swelling and I want to describe it. Okay, mild, moderate to severe. It looks like it's pretty severe to me, but I also wanted to describe it as to that concept we just talked about. Is this intracapsular or extracapsular swelling? Well, here's the joint space, and I think there is some around the joint, but there's a lot of swelling that goes way up here, okay, and way down here. And so I wouldn't say that this is confined and totally centered around the joint. It extends to the joint, but is not centered around the joint. It's not just focally around here. It's a lot more involvement. And so this would be described probably as extracapsular soft tissue swelling. And I always like to say mild, moderate to severe. So he's got pretty severe extracapsular soft tissue swelling around the distal aspect of the tibia that extends through the tarsal region. Okay. On the other hand, this is another tibial tarsal joint. Now, this swelling here, it's got some changes around the joint, but there's swelling here, there's some swelling in here, and if you kind of put a circle around it, now this swelling I could believe is coming from and centered around the joint space. So I would describe that as more intracapsular swelling than I would the last one had a lot of extracapsular swelling. Okay, this is a stifle joint, a lateral view of the stifle joint of a dog. And here's another pet peeve when you get out. As you get out with dogs, keep in mind that animals, whether it's a dog, cat, horse, elephant, whatever you want to talk about, animals don't have knees. Okay, people have knees. Dogs and cats and horses don't have knees. So when you get out, don't say this is a knee. It's not. It's not a human. Okay, this is a stifle joint. So if I look at this dog stifle joint right in here, and you don't know how to read these yet, but there's a bunch of swelling inside the joint space here. There's swelling caudal to the joint space right in here. All of this soft tissue opacity is swelling inside the joint. So we would classify that as intracapsular effusion or joint swelling. Okay. Okay, you can also, besides swelling, sometimes you can get subcutaneous emphysema or soft tissue emphysema. So these are little gas opacities inside the joint. We saw that when we looked at that first image of the elbow, when we, even on both views, we could see there was some little ill-defined lucent gas opacities in the area of swelling around that elbow joint. That would be an example of subcutaneous or soft tissue emphysema. So if you see soft tissue emphysema or gas opacities in areas of soft tissue, you have to think, well, number one, that's not normal. And number two, where did the gas come from? Okay, so it's got to come from somewhere. And so typically it either comes from the outside or the inside. So if it came from the outside, it's probably due to some type of penetrating wound, a thorn, a grass on, a gunshot, things like that, that introduce gas into the soft tissues. And now you can see it on the radiographs. On the other hand, it could come from the inside, and typically that you get an infection from gas-producing bacteria. So you get some of the clostridial, bacteria that are gas-producing bacteria, and if it sets up shop and you have a cellulitis or an abscess, sometimes it will form gas bubbles inside that soft tissue. It didn't come from the outside, but it came from the inside because of gas-producing bacteria. And then sometimes you get this is, I always call these party words. This is a party word. So this is where you could go to a bar and you start talking about doctor stuff and veterinary stuff. And you say, yeah, you remember that dog today that we saw a spontaneous pneumoarthrogram. And, the medical people, your friends and colleagues will know what you're talking about. But people around you think you're really weird, but they also think you're kind of smart because you know this weird language of medicine, right? Okay, so that's a party word, spontaneous pneumoarthrogram. So again, anytime you see these doctor words, what do? You take them apart and you try to figure out what it's saying. So spontaneous, we know what that means. It means it just happens on its own. Okay. It usually comes and goes quickly, right? So it's spontaneous. Okay. Pneumoarthrogram. Okay. What do we think that? What does pneumo mean? It means gas. Okay. What does arthrogram mean? Arthro has to do with the joint and gram is a picture. So this is a picture of gas in a joint that happens quickly. That's what that would mean, right? So this is some examples of gas. So now we have a surgical fixation of this femoral fracture. We got a big plate and screws, and these are cerclage wires, some staples along here. But now we have all these gas opacities in the soft tissues, along with swelling around that extracapsular swelling around that area. Okay, so because this animal just had recent surgery, these gas opacities are probably due, they're coming from the outside. It's probably due to surgical intervention, recent surgical intervention, and mucking around in there with the soft tissues. Okay, this is a spontaneous pneumoarthrogram. If you look real close in this dog's shoulder, there's a little lucent area right in here that we can see. Okay, that could be real. It could be a lytic lesion in that part of the scapula in the glenoid cavity. On the other hand, in this case, it's not. It's called a spontaneous pneumoarthrogram. Anytime, how many, show of hands, how many in there, how many people of you guys crack your knuckles? Okay, pretty much everybody does, right? And so when you crack your knuckles, okay, I don't know if you can, I'm trying, I don't know if you can hear it. Wait, okay, I can't, anyway. So when you crack your knuckles, that pop you hear is due to the presence of an instantaneous, spontaneous pneumoarthrogram. When you bend a knuckle or a joint in a certain way, if it's a synovial joint and has synovial fluid, and you bend it in a certain way, believe it or not, a very small bubble of nitrogen gas forms inside the joint and pops. Okay, and it pops, and that's what you hear is when that nitrogen bubble disintegrates and pops. Okay, that's what causes popping your knuckles. Okay, and so if you put stress on a joint anywhere in a dog that or cat that has a synovium in it, synovial fluid, sometimes you'll pop the joint and you form this spontaneous bubble of nitrogen that immediately goes away and dissolves back into the synovial fluid. Okay, and so that's a bubble which is caused by a spontaneous pneumoarthrogram. How do you prove it is a bubble versus a lytic lesion? Okay, well, the easy way to prove it is immediately just reshoot the radiographs and see if it persists. If it persists, it's probably a bony lesion. If it's not there anymore, because they go away in a second or less than that, if it's not there anymore, it's probably incidental and a spontaneous pneumoarthrogram. You will see these, and you don't want to confuse them for a lytic lesion of the bone. Easy way just to repeat the film and see if it's persistent. Okay, then we also have to talk about soft tissue mineralization. So when we talk about mineralization of these soft tissues, and you've probably already had this concept, we want to subclassify mineralization of soft tissues in two ways. It's either dystrophic mineralization or it is metastatic mineralization. Have y'all been introduced to that concept yet? Yeah, no? Sure. Yeah, okay. Thank you for answering. So dystrophic mineralization is mineralization of soft tissues due to dead or dying tissue that, again, the body's response to heal something up. Let's say you had a tendon tear, or you had an infection that's now healed up in the soft tissues. One of the body's ways to try to heal itself is it tends to mineralize the dead or damaged tissue. So it turns it into a little bit of bony material or mineralization. Okay, that's a normal response of the body when it tries to heal soft tissues. That is dystrophic mineralization. It's typically focal. It's not all over the body. And it's just in that one little area that had damaged soft tissues. Okay, if you would run the calcium and phosphorus levels of the serum calcium, the blood levels of calcium and phosphorus in those dogs, it's totally normal. Okay. The other type of mineralization of soft tissues is called metastatic mineralization. Now here we have to think about the word metastatic. Most people, when you hear metastatic, you think cancer. But truthfully, the word metastatic has nothing to do with cancer. Metastatic means it's all over the place. It's in multiple different spots. Okay, that's metastatic. So metastatic mineralization is not focal. It is all over the place. It's diffuse. And typically it's going to cause faint mineralization of a lot of blood vessel walls. So you'll see these linear tracks that correspond to where the aorta is, or the termination of the aorta, the iliac vessels. You'll see mineralization in there. And sometimes in the renal arteries and things like that, you can see mineralization. So metastatic mineralization is not focal, it's diffuse, and it's due to an underlying calcium phosphorus imbalance. So these are dogs that'll be hypercalcemic or hyperphosphatemic, can undergo metastatic mineralization. And that can be due to what we talked about last time, a parathyroid adenoma causing hypercalcemia. It can be due to secondary hyperparathyroidism, like renal secondary hyperparathyroidism or nutritional secondary hyperparathyroidism. It can also be caused by paraneoplastic syndromes. There are some tumors in the body like lymphoma or apocrine gland carcinomas that typically will cause the animal to become hypercalcemic. And that hypercalcemic environment can lead to metastatic mineralization. So two different concepts, both of them can cause mineralization of soft tissues, but you need to know the difference between the two. Okay, here is an example of this is a cat leg. So there's the femur, there's the stifle, there's tibia, and we got this area of soft tissue mineralization, kind of this ill-defined wispy area of mineralization. Okay, there's a good chance that is dystrophic mineralization due to something going on or something that was going on in this area of the cat's thigh. Okay, it's focal, it's confined to that area. It's probably due to dead or dying musculature tissue in that area. If you would evaluate the serum calcium and phosphorus levels in this cat, they're going to be normal. Okay, so that's due to tissue trauma. Okay, on the other hand, this is a cat, different cat, that has a really prominent, look how opaque that aortic arch is. That's the descending aorta and the aortic arch. And even the walls of it have these really thin, crisp, radiopaque lines. Here's the branch going out. That's the brachycephalic trunk and the subclavian going out here. So there's the branches of it here. And they're really opaque. They have mineralized, faintly mineralized walls. Even here, you can see part of the aorta coming around here. Okay. And that's due to metastatic mineralization. It's not due to dead or dying tissue. It's diffuse. It's all over. It's multiple blood vessels that are involved. So I would bet you money somehow this cat's calcium level is altered. By what it is, I don't know, but I want to check the calcium level and then try to figure out, does he have a parathyroid adenoma? Does he have chronic renal disease that could cause it? Does he have nutritional abnormalities? Does he have cancer somewhere that's leading to hypercalcemia? Then we try to figure out the puzzle. Okay, then we're going to venture off into this other concept called periosteal reactions. Okay, so this picture always freaks me out. Okay, and why would you think this picture would freak me out? Any ideas? I know y'all have voices. Why? Well, you don't talk, but I think if I was you, I would think because it's a slide of histopath. Okay, and I don't know why, truthfully, I don't know why they teach general practitioners in vet school how to read histopath, because nobody ever does it. Okay, if you go and you specialize in pathology and you become a pathologist, then you can learn how to read histopath. But I think it's a waste of time to teach general veterinary students histopathology. Maybe you show them a little bit of anatomy, but other than that, I think it's a waste of time. That's just my opinion. Okay, but that's not why this freaks me out. This picture freaks me out because why? It's in color. Okay, radiologists don't like color pictures. Everything we look at all day long is in black and white. Okay, maybe those PET scans, but that's just a color map, has nothing to do with the anatomy. Okay, so this freaks me out because it's in color, and I don't know. I would much rather it be in black and white. Okay, but if you look at it here, I don't have no idea what any of this crap is, but this is, I think, cortical bone. It's really dense and it's pink. Okay, and this is muscle tissue, and I know that because there's an MU on it. Okay, so that's the muscle tissue, and it's showing you that somehow this muscle is attached to this cortical bone. Well, if you remember from anatomy, there is a very thin kind of a plastic wrap, saran wrap coating around almost all long bones and almost all bones of the body, okay, called the periosteum. Okay, it's a glistening kind of a white, clear coating. Well, this layer here is the periosteum. I know that because it's got a P, okay? And so the periosteum is the covering on the long bones, and the periosteum is hooked to the long bone, the cortical bone, by these things called SF, which you remember from anatomy is called Sharpie's fibers, right? And so Sharpie's fibers hook the periosteum to the cortical bone, and then the muscle can hook to the periosteum. Okay, so that's all I need to say about that, other than let's get back to black and white pictures. Okay, so if we look here, this is part of a long bone, probably a femur or something like that, a long bone of this dog. And if we look here, the cortex looks nice and well defined. That's the cortex. Here's the cortex of the bone. And then we have a cortical bone surface out here, the cortical surface of the bone, this outside part. Again, it's well defined. Okay. And then the inside surface of that cortical bone, where it joins the marrow cavity, is also well defined. That surface is called the endosteal surface. Okay. But both of them are well defined. But then I've got this weird thing over here. Look at this. I've got this ill-defined area of mineral opaque stuff. It's solid, it's well-defined, it's homogeneous for the most part, and it's sitting on top of the cortical bone right here. Okay, there's a similar thing here that is sitting on top of the cortical bone back on the caudal aspect of this portion of the long bone, except it's kind of extending into the soft tissues. Okay, so what this is called a periosteal reaction. It is a reaction that the periosteal layer covering over the cortical bone can develop due to some response to injury. Okay, and we want to characterize radiographically periosteal reactions as to do they number one, do they have one, and number two, what kind of periosteal reaction it is, because there's some of them that we know are typically non-aggressive due to something that happened that's non-aggressive, and there's other ones that are super aggressive in their appearance, and the etiology, what causes them, is different. So this one here is a solid homogeneous periosteal reaction, and those are typically non-aggressive. Okay, very good prognosis, and it's usually due to some type of blunt trauma to the bone. So the dog or horse or whatever it is ran into something and banged their leg on something, and it caused the periosteum to become pissed off, and it makes new bone, and it causes this well-defined, homogeneous, new bone formation around the leg where it got injured. Okay, but it's solid, it's homogeneous, it's non-aggressive. If you leave it alone and you re-radiographic a month or two later, it's going to look completely normal and gone away. Okay, it's just the body's response to injury and try to stabilize and heal the bone. Okay, this one back here used to look just like this one, except there's a muscle that hooks on back here and it kind of pulled it away. Okay, so a smoothly marginated, solid, homogeneous periosteal reaction like this, prognosis is very good. It's non-aggressive. It'll go away on its own, usually due to some type of blunt trauma. Okay, this is a similar periosteal reaction of a long bone. You can see there's back here on the caudal cortex, it's kind of ill-defined. Up in here, it's still pretty homogeneous, but the surface of it is a little more irregular in shape than the last one we looked at. And it almost looks like it's lamellated and like an onion skin lamellated appearance. It's got this area underneath it of lucency between the periosteal reaction and the cortical bone itself. And a lamellated periosteal reaction, sometimes there'll be several layers. There'll be 2 or 3 layers alternating radiolucent and periosteal reaction that's solid. Okay, a lamellated periosteal reaction is usually one that is kind of semi-aggressive. It can also be due to blunt trauma, but a lot of times it'll be associated with an infection. And an infection of the bone is called osteomyelitis. Okay, and so sometimes these are associated with osteomyelitis or an infection of the bone that may be of bacterial or fungal origin. And the way I think about these, the way I remember them, is the lamellation is caused by, let's say this dog comes in and he's got an osteomyelitis caused by staph, a staphylococcus bacteria, and he's painful, and so you put him on antibiotics. Okay, and he's on 2 weeks of antibiotics, and he starts to feel better, and so the owner quits giving them to him after a week. Okay, he's not on them long enough, and after a week, what's going to happen? Well, sometimes the infection is just going to rear back and come back. okay, because we weren't on antibiotics long enough. So when the infection comes, there's the initial periosteal reaction due to the osteomyelitis, and then you take them off antibiotics. Well, now the infection comes back and we get blood and pus that starts to form. Well, now he's lame again. So you put him back on antibiotics. And so then underneath that, you're going to get another layer of smooth periosteal reaction. Well, then the owner doesn't leave him on antibiotics long enough again. So then you might get another layer underneath that of lucency. So that's the way I always thought about these lamellated periosteal reactions. It's kind of semi-aggressive. These can be due to blunt trauma, or they can be due to osteomyelitis. That bone might have a little infection that kind of waxes and wanes and kind of comes back. Okay. Here's another periosteal reaction. This one is anything but smooth and homogeneous in its appearance. Okay, with this periosteal reaction, it's very irregular in shape. It kind of almost has a spiculated-like appearance, almost a sunburst appearance around this bone. Obviously, a lot of extracapsular swelling surrounding that area. It's not centered just around the joint. It's mostly centered up here. Okay, so this is an aggressive, when you see a spiculated, kind of poorly defined periosteal reaction, that's an aggressive periosteal reaction. That is usually due to something that is a really severe chronic infection, a lot of times maybe even fungal disease in the bone, or it can be due to cancer. Okay, so that is a spiculated aggressive type periosteal reaction. Looks totally different than a smoothly marginated solid periosteal reaction, doesn't it? Looks totally different than a lamellated periosteal reaction. Okay, it's kind of its own thing, and it looks very aggressive and kind of ill-defined and spiculated. Okay, well, if we go to the next type of periosteal reaction, then we can get to this one here that's got some spiculations too. Then now this one is so aggressive, it's eating the periosteal reaction away itself. And now we get just these little wispy areas, very thin wispy areas of bone in here, kind of this amorphous periosteal reaction. Some of it has a spiculated appearance, but we get a lot of lysis of even the periosteal reaction itself. Here's the cortical bone here. That's normal looking or normal cortical bone. That's normal cortical bone. Nice, well-defined endosteal surface, nice, well-defined outside surface, and the periosteal surface there itself, okay? But when I come down here, that part of the cortical bone is completely lytic. There's something so aggressive in there, it's eating away the cortical bone, and it's eating away even the periosteal reaction that it generates. Okay, that's a super aggressive amorphous periosteal reaction that for the most part, that's going to be caused by neoplasia, bone cancer, osteosarcomas, and things like that. Okay, if you look where it joins more normal bone, it's got a little lamellated periosteal reaction here. So that's probably dissection of blood and pus and maybe neoplastic cells proximally underneath the periosteum next to the cortical bone, causing that lucent little line right in that area here. And as it dissects proximally, it will actually lift the periosteal reaction as that inflammatory tissue or neoplastic cells will lift the periosteum away from the cortical bone, okay? And that condition has a specific name, okay? Here's another aggressive lesion of this dog's distal tibia. And so this is a neoplastic condition. It's probably an osteosarcoma, and there's neoplastic cells and blood and pus and all kinds of nasty stuff in there. And as this tends to spread proximally, it eats the bone away, but it lifts the periosteal layer away from the bone as it dissects between there. And that triangle where it's lifting the periosteal cover off the bone, people named it Codman's triangle. Again, this comes from the human medicine literature. So Dr. Codman back in the day described this and put it in the literature, and from then on it became known as Codman's triangle. Is due to a lifting of the periosteal reaction where an aggressive bony lesion is migrating underneath the periosteum and lifts it away from the cortical bone, okay? That you only see Codman's triangle with things that are really aggressive. Okay, this is a great place to stop and take a break, and we're going to come back and talk about a few bony terms, if you will. So let's take a break here, and we'll see you in about 10 minutes or so. Thanks.